We start out with 4 panelists. They will speak to a specific question, and they will not talk about the whole program of a given country, but we will ask them to specifically talk about an issue that is important in a given country. And we are starting out with France. France is a country that has made very good strides forward in providing hepatitis C treatment and has, within the European context, one of the highest coverage rates, even though it is still very, very low, and we will hear about that, but still comparatively higher than it is in other countries. And I am inviting Madame Laurence Caté, who is the head of the HIV, STI and Hepatitis Office in the Ministry of Health in France, to give us some reflections. And specifically, Laurence, maybe you can tell us what are some of the successes that you see, what are some of the factors that have contributed, but also what are the challenges on the way forward?
Thank you. Good morning, ladies and gentlemen. Bonjour, mesdames et messieurs. In the name of Benoît Vallet, Director General for Health, I thank you for their invitation, the organizer, WHO, especially Mr. Hirnschall and Stefan Victor, the Scottish government, and the World Hepatitis Alliance. I would like to remind you that France is a country where prevalence of hepatitis B and C are low, and at the present time, the remaining problems concern mainly some key population like migrants, prisoners, drug users, and MSM, men who have sex with men. In France, since 1999, 3 national plans against viral hepatitis have been implemented. The first one during the period 1999 to 2002 was exclusively dedicated to hepatitis C. The second one was renewed in 2002 and during the period 2002 to 2005, and it was extended to include the hepatitis B infection. Within the decade, both plans allowed a dramatic improvement in the number of patients screened and treated, progress made in the prevention, screening, and access to therapy seems, however, insufficient, thus resulting in the development of a third plan with the period 2009 and 2012. This plan included 5 strategic goals. The first one, reduce risk of hepatitis B and C, develop new screening strategies for hepatitis B and C, improve access to health care and the quality of care for patients, adapt the recommended measure to inmates, and finally reinforce research to improve epidemiological knowledge and comprehensive patient care. Nevertheless, some weaknesses in tackling these 2 diseases were still identified by the evaluation carried on in 2013. Among them, insufficient preventive actions, including hepatitis B immunization, difficulty of access to testing, screening, inequities in access to treatment and care, cascade of care, due to social barrier, use of drug, language, homeless, and geographical reasons. A change in the strategy was then proposed. Fighting against hepatitis would no longer be the goal of a specific plan, but had to be a part of a national health strategy set up in 2013. The main priorities of our national health strategy are to improve the prevention, including testing and screening, to reduce health inequities, and to organize a coherent care pathway for each patient. There was also a strong need for comprehensive and updated recommendation regarding the diagnosis and care of hepatitis B and C. A group of multidisciplinary experts and support group representatives was asked to produce recommendations, taking account the major advances in diagnosis and treatment of hepatitis B and C. This report, which can be used as a guideline, has been published in May 2014. It is called Prise en charge des personnes infectées par les virus de l'hépatite B et C, care for patients living with hepatitis B or C. The main priorities identified by this report are to improve hepatitis B immunization, especially among teenagers and young adults, develop new actions in harm reduction policy, to develop testing and screening by improving strategy based on risk factors by systematically screening HBV, ACV, and HIV, at the same time, and by providing new tools like rapid tests for ICV. With counseling, rapid tests will be implemented with counseling mainly towards population groups difficult to reach. To improve access to cure and care for patients by pre-treatment collaborative approach, monitoring and support during treatment, therapeutics patient education, identify the social needs and provided social measures, to maintain high-level research activity, including projects in public health and social science. The Ministry of Health provides fundings to our HIV hepatitis research agency for the cohort Hepater, which will include 25,000 patients for 8 years. The new health law, currently debated in the Parliament, will include several measures which will help to tackle this priority. For instance, experimentation for supervised injection room will be allowed, as well as using rapid screening tests by non-health workers. Most important factors responsible for the success of the plan. After 3 successive plans, we identified several factors responsible for their success. First of all, the governance of the plan, with the involvement and strong collaboration of all the stakeholders, including patient support groups. At the regional level, regional health agencies are also involved, especially the ones with higher prevalence rates of hepatitis. The second factor, the specific organization of the health system, with 32 reference hepatitis centers implemented since 1975. Their mission is to coordinate public and private sectors for patient management and follow-up. They also train healthcare workers, develop treatment guidelines, and carry out clinical research. They are of high value to better framing the proper and efficient use of the new treatment.
Excuse me, Madam Caté, can you
Yes.
wrap up, please? It was meant to be a 3-minute intervention.
Okay. And the 2 other factors, it's the long-term planning of prevention policies. Since the 19th, prevention actions have been implemented to tackle different routes of transmission of hepatitis. For high-risk population, for instance, drug users, harm reduction policies have been developed since 1994, including specific community settings. Providing treatment as soon as they are available is the 4th factor. Free treatments are available for all the patients with hepatitis B or C. There is also a process to provide treatment to all patients without alternative option as soon as the drug is available with sufficient data, even months before the granting of the marketing authorization agreement. This process is called autorisation temporaire d'utilisation. It's a compassionate use of new medicine. Thank you very much for your attention and for your invitation.
Thank you very much. And if I may ask a follow-up question, Laurence, with those efforts, what is the treatment coverage with hepatitis C, interferon-free drugs at this point in France? Just to give us a figure there.
You want to know the indication for the treatment in hepatitis?
No, the coverage, like
the coverage.
The percentage.
the coverage of the treatment, the population
the treatment eligible population, yes.
I don't have the score
Okay.
at mind, but for hepatitis B, we allow, before the marketing authorization agreement, this compassionate use of new treatment since 2012.
Right.
And it's taken in charge for patients with severe fibrosis since last year.
Okay, because we understand it's in the magnitude of 6%. Just that's the figure we normally use for France. But so all this to say, great efforts, but still a very long way to go. And obviously the plan that you have presented certainly gives us a lot of hope that there will be treatment will be increased, and specifically that you also talked about harm reduction, because obviously in many countries there are key populations, specifically injecting drug users, that are very highly affected by hepatitis C. So obviously in many European countries that is, and other countries, that is most relevant. We are moving now back to Asia. We are moving to India, and we are inviting Dr. Neeraj Dhingra, who is the Deputy Director General in the Ministry of Health in India. And I would like to ask Dr. Dhingra, who we know is himself a very adamant sort of supporter of the hepatitis agenda. Obviously, India has a lot of health issues, and you will have to prioritize. But can you share a little bit of what the state of affairs currently is with regards to India's prospect of developing a national plan that would be comprehensive and would incorporate the various aspects of prevention and treatment?
Thank you very much. At the outset, I would like to thank the summit organizers, WHO, Hepatitis Alliance, and especially the Scottish government for inviting me to come over this. This is the most opportune time for India as we embark especially on Hep C, looking into the Hep C treatment and also other issues. I think in India we have all types of viral hepatitis. All 5 types do exist there. And especially the enterically transmitted A and E virus are important causes for acute hepatitis and also liver failure. For example, hepatitis A is around 10 to 30% of acute hepatitis and 5 to 15% of liver failure. And similarly, E, 10 to 40% of acute hepatitis and 15 to 45% acute liver failure in India. Hepatitis B, C, and D very minimal in India, but these are the silent epidemics that are coming up in India. And these are posing a major public health challenge as far as we are concerned. Hepatitis B and C main transmission is through injecting drug use, people who inject drugs, and also to some extent, iatrogenic also is there. In 2014, Government of India launched National Program on Prevention and Control of Viral Hepatitis. And mainly at that time, it was to set up the comprehensive lab surveillance across the country and also to generate awareness on viral hepatitis. The main things that are going on in India for prevention are mainly there is a mandatory screening for all blood, for all hepatitis B, C, along with HIV, malaria, and syphilis. Hepatitis B immunization in children is a part of universal immunization program. There is also a national policy on universal safety precautions that is also there, which includes of all safe injecting practices in all healthcare settings. We have a comprehensive harm reduction strategy, which covers around 132,000 drug users, where needle exchange programs and other services are provided. The main thing now, the challenge that we are facing is on Hep C. If you look at, we do not know the actual prevalence of Hep C. It's estimated around 1%, and the number that are estimated is between 4 to 12 million. So there's no correct estimation of the numbers that are available to us. So to get around to this, what we have done is, like, we normally carry out an HIV sentinel surveillance where around blood samples from key population as well from antenatal mothers are collected for 500,000 samples we have from this latest. Along with WHO support and Indian Council of Medical Research, we're going to do all in this 500,000 blood samples and Hep C. So we may come to know about the comorbidity between Hep C and this. There are issues about advocacy and awareness also. The major is people are not aware about the need to go for testing, and so they continue the transmission. There are challenges in diagnostic testing and treatment. Early diagnosis of viral hepatitis infection, especially affordable, effective point of care, all these staging tools that are required are still to be developed and put. And along with this is also the fund crunch that we face, that fund that comes from external sources and many a times within the Ministry of Health to launch an effective program of Hep C becomes a problem. Special challenge that remains with us is to linkage with the general health delivery system that we have, which covers all over the country, right up to this. So all those development of modules, capacity building, all those things is a major challenge as far as we are concerned. But initially what we are starting to find out, the pockets wherever the injecting drug use is high and also the Hep C likely to be high, to take them and then go on. Negotiations also are going on with the pricing of Hep C drugs. The possibility the drug costs may come down and then definitely the treatment would start. Thank you very much. Thank you.
And India obviously is one of the countries, or is the country that has given the world very cheap drugs for HIV. So we hope and we see some of these developments might also will occur for the DEAs for hepatitis. Thank you very much. We are moving back to Europe and close by actually to England. We have with us Professor John Watson, who is the Deputy Chief Medical Officer for England in the Department of Health in the UK. Professor Watson, in England, obviously similar to France, I would say, in many other countries, hepatitis is primarily a problem of key populations. And for hepatitis B, migrants obviously are an important group, including others, of course. And for hepatitis C, as we've already mentioned, is injecting drug users. So what are some of the approaches that England is using to reach these people and really to move towards a comprehensive approach in addressing the needs of these key populations?
Thank you very much. If I could start by saying it's a pleasure to be here in Scotland. It's always a pleasure to come and visit Scotland, but particularly appropriate, I think, because of the leading role that Scotland has played within the UK in tackling viral hepatitis, and I'd like to acknowledge that. I'd also like to pick up on Charles Gore's comments earlier today about the role of advocacy groups. Advocacy around hepatitis has been particularly prominent and effective in the UK at raising the profile of this as a condition, and this has not always been the easiest thing, but it has been a very constructive an arrangement and has helped us to move forward in this country. As you've indicated, although the overall prevalence, like in France, is low, hepatitis B among immigrants and hepatitis C among injecting drug users are the problems, and we know a lot about that because of the surveillance carried out by our organisations in England, Public Health England, and in Scotland, Health Protection Scotland. In order to provide the information, we need the testing to be carried out, and we've been supporting and promoting increased testing with general practitioners, family doctors, in prisons, but also within community drug services, and testing has increased. As far as access to treatment is concerned, that, of course, and we wouldn't be here otherwise, is a challenging business. It's been challenging in the past because the treatments have not been as good as we'd like, and they've been very unpleasant, as we've heard. The development of the new treatments coming on stream now is really very promising indeed, but of course, we, like other countries, face the challenge of cost and the need to balance this with other demands on our healthcare budget. We turn to our National Institute of Clinical Excellence to look at new drugs and new developments and provide advice about their cost and their appropriateness, and NICE has been working on that over recent years and has approved a number of the new drugs for treating hepatitis C. And we're implementing the advice of NICE too slowly for some, I'm sure, but in addition to that, we have accelerated access schemes for those with cirrhosis. But I'd like to conclude with the issue of prevention. We have felt for many years that this is a particularly important part of our approach to hepatitis, particularly through our community drug services. And even with the advent of new and promising and effective treatments, we consider that the importance of prevention is not diminished, and we feel that we should continue to maintain our effort in preventing the development of these infections in our populations, including those minority populations. Thank you.
Thank you very much. And last but not least, we're moving to China. We've already heard about China earlier today. It's a large country, obviously, with a huge population, but also with a substantial hepatitis burden, of course. Out of those 1.45 million people who die annually, about 400,000 actually die in China. So if China moves forward, you know, we already will make an important step towards our global elimination agenda. So China, we have two colleagues from China who will share a little bit what the situation there is. We have Dr. Yanhong Guo, who is the Deputy Director General from the Ministry of Health and Family Planning, and we have Dr. Lu Ming also from the Ministry of Health. So maybe you can elaborate a little bit on sort of the success in China that you have had specifically with the early introduction of hepatitis B vaccine, because really the fantastic phenomenon that we see in China is now that the younger age groups basically are quite free of hepatitis, which is fantastic. But obviously you still have a large cohort of sort of somewhat older people who still require treatment. And obviously also you have a substantial hepatitis C burden. So can you share a little bit of what the ingredients for the success were, but also what the way forward is in terms of addressing some of the challenges and some of the access barriers that still exist for treatment?
So thanks, Chairman. So that's China's for hepatitis B control. The main policy is just we try to improve the high coverage of hepatitis B immunization coverage rate. So as you can see that China, we have in 2002 just integrated the hepatitis B vaccine into the EPI schedule. And now, but we keep a high level of hepatitis B vaccine immunization coverage rate, but also we have made some challenges. The first is how to sustain high level of vaccination coverage. The existing problem is including low birth dose coverage in certain areas, low screening rate in grassroots levels. So that's for China, for our government, just to try to make up multiple strategies to implement to improve timely birth dose. The general approach is to build bridge between delivery service and the vaccination service. Intervention strategies include improving hospital delivery rate, training healthcare workers, increasing public awareness on the importance of timely birth dose, and other micro plans like providing a subsidy to providers who provide door-to-door vaccination services in order to increase coverage among home births. So for the second strategy, just we focus on the group that is not included into the EPI schedule, the other group that is adolescents and also adult. So that in 2009 to 2011, the Chinese government just mobilized some resources to carry out a nationwide hepatitis B catch-up vaccination among children and adolescents. So in total of 68 million under 15 years adolescents were vaccinated. So third, we just try to make up a mechanism to implement and strengthen the different department cooperation, such as the Department of Disease Control and also the MCH. So maybe in the next week, with the support from WHO Beijing office, we will hold a meeting from our department and also MCH, try to discuss how to give more chance or more opportunities to the children with the mother of the positive of hepatitis B surface antigen. So maybe in the near future, we try to set up new strategies for that group. So for the treatment that you have said, we just have three main strategies. The first is to try to strengthen the national treatment strategies. We have set up some national strategies, and for the near future, we just encourage and for the province level to implement that strategies properly. So for the second, we just encourage more and affordable and effective drugs into the social welfare systems, so that will be benefit more of the adult persons. So for the third strategy, we just set up a national essential technical support project. That means with the project support, we just set up over 30 special hospitals, mainly focused on the treatment of hepatitis B and hepatitis C. So that means that for China, at least one province, at least one hospital in each of the provinces have the hospital to focus or benefits for the hepatitis B or hepatitis C patients. So that with the support from the Ministry of Health and also with the Ministry of Technical Science, so maybe near the future we can see the result of that. Yeah, thank you.
Thank you very much, and rest assured of WHO's support. You are very well located. Dr. Shin, Regional Director, is sitting here, so I'm sure there will be some follow-up conversations. But really, I think it is encouraging to see that there's movement in China also towards treatment. And obviously, as you're saying, there's large numbers that need to be addressed and tackled. So bringing the prices down, as in all other places, is obviously one of the key elements to ensure that the access. Now, we have heard basically examples from 8 countries. They were all slightly different. I think there's also some convergence that we are seeing and hearing, where I think all countries are really moving towards comprehensive plans. And that's really great, even though the focus and the entry point may have been different in different countries. But I think we clearly see, even in countries where obviously the treatment access has been highly important and has been highly publicized, it's very encouraging to see that the safe injection policy has been launched there, and really Egypt is also moving towards a comprehensive plan. The same is true, I think, for Uganda, for the Gambia, and really also it's encouraging to hear that India is really seeming to gearing up towards developing a comprehensive plan, and obviously all other countries. We have some time left for interventions from you all, not as much as we would have hoped for. We have 4 microphones in the 2 galleys. Please use those. Anybody who wants to make any contributions on the topic is, of course, very welcome. I just would like to recognize that we have additional countries that are represented by their ministers, and we're very happy and grateful for that, including Albania, Burkina Faso, the Democratic People's Republic of Korea, Mauritius, Samoa, Sudan, and Swaziland, in addition to the ministers that have already spoken today. But please, if there are any additional aspects on national leadership, national action, or if there's any questions to the panelists, this is the moment. Microphone 4, please identify yourself.
My name's Jack Wallace. I'm from La Trobe University. One of the kind of key issues that came from this morning's presentation, and there seems to be a disconnect, one of the kind of key issues that came from people with viral hepatitis was around stigma and discrimination. None of the panel members have actually discussed stigma and discrimination, and I think it has a fundamental impact on any of the development and implementation of national strategies. It affects prevention, the support of the community for good prevention strategies, particularly around needle and syringe programs. Nobody wants to go and get tested for an infection where you are in countries such as China and Philippines, where you are likely to be restricted in terms of education and employment. That's going to essentially affect stigma and discrimination, will essentially affect the development and implementation of testing policies. With treatment, I did a needs assessment of people with viral hepatitis in China, and one issue was the fact that people would, some of the people would talk about preferring to pay for treatment themselves rather than going through government agencies because of stigma and discrimination fundamentally affected their access to employment and education. I think one of the I'm from Australia, one of the benefits of the national hepatitis C and hepatitis B strategies was the inclusion of stigma and discrimination because it does affect every aspect of the implementation of the national strategies.
Thank you very much. We take a few, and I think it's obviously a highly relevant point as we have heard from the previous session. We take a few questions and then go back to the panel. Microphone 1, please.
Laurence from the United States. I have a question about India. Your death rate from hepatitis A seems quite high. And what, do you have any explanation why? I mean, very few people die in the United States from hepatitis A. What is the difference and why do you have such high mortality?
Okay, thank you very much. Microphone 4, please.
Yes, my name is Tove Frisch. I come from Stockholm. Stockholm has more than 2 million inhabitants, so many more than the whole of Gambia. And I don't want to diminish the work that you're doing in Gambia or in Georgia, but if I had any power in Gambia, I would make a very, very simple national plan. We are going to test absolutely everyone in this country. And the ones who need, we will give them the short-term 3 months treatment now, and within a year or a year and a half, you will be the first country in the world to have no hepatitis. Just a good advice. Thank you.
Thank you, Sweden, fixing the Gambia. We'll come back to that. We have one more person at microphone 4.
Thank you. Neeraj from Untitled Foundation in Mongolia. I have a question for Georgia. What is the liver cancer mortality burden for Georgia and liver cirrhosis?
Okay, and we take one last intervention, and then we go back to the panel. Microphone 4, please.
Thank you. I'm Céline Grillon from Médecins du Monde. My question is also directed to the Georgian representative. I would like to ask if the elimination program has a specific intervention targeting people who are injecting drug in Georgia as they bear a high amount of the prevalence, and I would like to ask if there are strategies regarding reinfection prevention, and also if Georgia consider integrating other molecules, considering that Havoni is not effective on genotype 3 that is present in Georgia. Thanks.
Thank you very much, Celine. Let's go back to the panelists, please. We have a few requests. The one that goes to all of us on the issue of stigma. Have you thought about this? Is this part of your plans? What are the interventions that you would address? Some of the specific issues, the employment, exclusion from employment, etc. And then we have questions that go specifically to India, one to Gambia, and two to Georgia. Maybe while we all think about stigma, may I ask India, please?
Mainly because of delayed diagnosis and an incorrect treatment that is given. So those are the major 2 contributing factors. And they don't come to the medical system as such. That's a delayed thing that says. This is what but there's no study that I have to quote on this aspect. Thank you.
Thank you. May I ask Minister Se to respond to the suggestion from a colleague from Sweden? Basically test the full population and identify those for treatment? Is there any reaction that you would have there?
Yeah, as a country, what we have to prove, and we have proven that hepatitis B can be prevented, and we have the evidence, and we saw the efficacy of the vaccine. Yes, but if anything have costs attached to it, if the vaccines were made in the Gambia, I don't see any reason why we will not go full-blown to vaccinate everybody and eliminate. But a percentage of 0.41, we are happy as a country, but we are not comfortable as a region. That's why I say this have opened the way, which we want to champion. I hope you come on board, support us, then we look at this from a regional point of view, which we want to champion. Not only the Gambia, but for the whole sub-region. But it has some resource implications. And together, the government alone cannot do it. Thank you.
Okay, thank you very much. Dr. Shin wants to make an intervention.
Yes, so I never been visited the Gambia before. However, as a regional director of the WHO, working with many different countries in my own region, 37 countries and areas, each society, each country has different level of development, different context of this all understanding and capacities. I think that we have to understand the multiplicity of this complexity of this whole world, how we work together. I think this is obviously, but I said Gambia, I don't know, even though I don't know about the Gambia, but achieving 98% of birth dose, that's quite obviously remarkable, amazing success. I just like to just congratulate it again. And sometimes simply it's very easily accessed and routine things in some developing countries very, very difficult. I just like complimenting on it. Thank you.
Thank you very much. I would like to give the floor to Georgia. Minister, if you could address some of the questions that came up there. Also, if you might want to also comment on the stigma issue.
Yes, thank you. Stigma issue is really important because without involvement of patient society and without appropriate information campaign, we cannot reach the result. And I would like to comment regarding mandatory screening. You know, we cannot resolve problem with such rapid and strong approaches because stigma is stigma, and we have to work with patient society, and it requires very tailored approach. And I would like to answer to questions. First, regarding liver cancer mortality, I hope I will get exact data in a few minutes, but now I can say that it's quite high compared to other cancer diseases. Regarding risk groups like injecting drug users and other risk groups, two main issues. In first phase that we already started, only inclusion criteria is severity of clinical condition, regardless of belonging of any other risk groups, because severity of disease does not not in correlation with the risk group, while incidence is high in risk groups. So in first stage, we did not make any differentiation for risk groups and other people, just only clinical criteria. For long-term elimination that we are finishing working now, of course, risk groups will be considered because there are two approaches. One, we would need key for patient society, and we are closely working with representatives, NGOs, societies, etc., to let them approach treatment. Again, this is stigma issue. And other one, they are requiring very strong control for reinfection and prevention of appearing reinfection rate that is very high. So regarding Harvoni question, fortunately this medicine is already registered in Georgia, and hopefully during this year we will switch from Sovaldi to Harvoni. That would give us new chances, and in case of genotype 3, we already developed guideline that requires addition in few cases interferon, and hopefully this project also would be successful. Thank you very much.
Thank you very much, Minister Sergenko. I would like to invite any of the panelists who might want to address the issue of stigma. I think it is really not a negligible issue, and indeed, is this considered in your planning for the future and in your national plans? Yes, please.
Okay. First, social stigma or social stigmatization will change when hepatitis C becomes an easy-to-treat disease. Step by step, the patients will look at, or the society will look at hepatitis C differently. the governmental stigmatization or the authority stigmatization. In Egypt, patients with hepatitis C is a pre-employment test, and those with hepatitis C were prevented from employment in most of government agencies and private companies. Last month, the government decided to prevent hepatitis C from being a pre-employment test, and patients with hepatitis C, if they apply for a job, they get treated and are hired. So it's no longer prohibiting employment, hepatitis C in Egypt. So we hope that social stigmatization will follow, and we hope that other countries that require hepatitis C testing on granting visas for work in other countries, that they will follow suit, and at least patients who are treated and cured from hepatitis C can be allowed to travel and work in other countries.
Thank you very much, Professor Wackett. This is really very encouraging, and we can all hope that many other countries will follow suit.
Yes.
Jacinto, Uganda?
Yes,
What's
thanks
the
very much.
situation there?
I just wanted to add on our experience from Uganda on the access to testing and also for stigma. In fact, in Uganda, almost everybody wants to be tested, especially for hepatitis. And the minister directed that we, at any one point, any person who goes for health care should have access to testing for hepatitis, HIV, syphilis, and malaria. For now, we are including hepatitis B only, but in the future, when we expand, we'll also include hepatitis C as a mandatory test. The turn-up for testing is very massive. In fact, more than when people are called to do single testing for HIV. Secondly, as my colleague has said, the stigma is there when nothing can be done. But now that there is access to medications and other vaccination programs, we have found that issues of stigma are beginning to come down, but they are still there. There are people when they denied employment, they denied, some were expelled, even including students, but we hope this will be addressed, and we shall also learn from the other countries as they proceed.
Thank you. Any other comments on the stigma issue? Yes, please. Laurence.
Yes, in France we are aware also of the stigma in discrimination is a sort of break to prevention. We have listened to learn, I think, from HIV stigma policies against stigma. That's why the report that I told about in my speech, the report Care for Patients Living with Hepatitis B and C, focused on social needs and providing social measures for people living with hepatitis B and C, and on peer interventions in rapid tests or community settings, in the support for patients. We work also with NGOs in the steering group, in the steering committee, which is in charge of the follow-up of the report. And I would like to mention that there's an NGO representative who could chair the steering committee, and it's support for that point. Thank you.
Thank you very much. I think this, we have one very last intervention here, and then we need to wrap up. Yes, please. Yes, it's on.
Good afternoon. I am Dr. Gako from the Philippines, and I would like to react to the stigma issue. Actually, stigma can be addressed by both parties, the one providing the treatment and the one that's experiencing the disease. That's the patient. In the Philippines, we have the Hepatitis Association. This is actually a developing group that group of gastroenterologists who can explain the disease so that the stigma can be eliminated. No? When they explain it to the public or to the society that it is curable, that with proper preventive measures, the the spread of the disease can be controlled, then I think that the stigma there can be minimized. On the part of the patients, we have also the yellow warriors. These are actually the patients that have been sick of hepatitis, and they can be source of this information also, because they are the ones feeling the disease, and they can talk to the other patients and to the public, and they themselves should not feel stigmatized. So I think with development of these two groups, we can reduce the stigma issue.
Yes. Well, thank you very much. Obviously, lots more discussion about this topic needs to happen. We have in the area of HIV that was mentioned, there has been a discussion for 30 years, and I think the world has come a long way in reducing stigma and improving some of those, and removing some of those barriers to work, to travel, etc. But still, there is quite a lot of there. So it is important also that we do address this very early in the conversations on hepatitis in the context of national planning. What we have been trying to achieve in this session is really to demonstrate a few things. One is the importance of national leadership and courage. And I think we've had a few examples where really countries are moving forward, and they're moving forward sometimes against all odds, and they're getting somewhere. So this is what we want to refer to as champion countries. Obviously are very important to set these examples, to really share the lessons that they have learned and really influence others in other countries. So this government ownership, taking charge, taking responsibility for a major health problem is obviously very important, and we're seeing very encouraging signals here. The other element that I think is coming out of this discussion is that different countries have different priorities and different entry points, and that's very natural because the epidemiology is different, the resource situation is different, the geography is different, etc. But it seems that there's really a large convergence towards comprehensive development of comprehensive plans. And we say comprehensive, it really means that we need to tackle prevention, we need to look at testing and diagnosis, and obviously also to treatment and care. And also we need to look at what I would like to describe as enabling environment, factors that constitute barriers to care, and stigma and exclusion from work, etc., is one of those. So hopefully all countries will really move towards comprehensive planning. And the third one, third lesson that I think came through quite a bit in the presentations and statements is the need for partnerships. Obviously, the governments needs to drive that, but they will not, in most instances, be able to do this alone. So it will require all types of partners, technical partners, in some instances funding partners, in some instances public-private partnerships, etc., to really move this forward. WHO has developed a guide, and we are using this event or this opportunity to launch that. And it's a manual for the development and assessment of national viral hepatitis plans. So it is about developing the plan, but also assessing the plan. Really, it's about this whole accountability framework that has been mentioned a couple of times. We will use this manual tomorrow when we do a simulation exercise. You will also get copies at the WHO booth. Please do visit the booth. And I also would like to recognize that this is the work of many people in WHO and many partners that have helped us. But I also want to recognize Dr. Hamanchi, who is a staff of the Global Hepatitis Program in WHO, who has taken the leadership on that. And if you have any question or criticism on the document or any suggestions for improving it, this is a provisional document. Hande is your first name. Please raise your hand, Hande. Hande will be happy to engage with you in a conversation, and also we're obviously happy to receive an email from you in WHO. So with that, I hand back to Dr. Shin, who will close the session.
Thank you, Gottfried. I think all I like to wrap up, conclude, is that appreciation to all our speakers and panelists, and also participant audience, that I think we had a good session. I really liked this will be really momentum that we can start really from here, that really doing things for, I think, this humanity and saving lives. I already thinking that we have 1.5 million people mortality caused by these hepatitis issues every year. But I'm thinking still, we have 400 million people currently infected by hepatitis, like 250 million hepatitis B, and approximately 140 to 50 millions in hepatitis C. And we heard from issues from patient groups and stigma, all this. I think something really we have to do. I think all this should be start from National Action Plan. I think we really heard that excellent kind of model countries that actually we heard from. But I hope that we all, as a WHO, we are working even further. And I think with you all hepatitis leaders in the global, we wanted to get the level, we wanted to achieve elimination of hepatitis as a whole by 2030. Thank you very much.